for that generous introduction. I hope you're still
Wait.
awake. Okay, so here we go. I'm not going to ask anymore if you're familiar with this TV show because I'm sure all of you are.
The young ones don't know. The young ones don't know.
Oh yeah, there are young ones here, sorry. Okay, so better, stronger, faster. So this was the textbook that that introduced me to this kind of practice a couple of decades ago. And Dr. Robert Goldman mentioned that sports medicine was the predecessor of anti-aging medicine. Although anti-aging medicine now comes with many, many other names as well. So I'd like to thank Dr. Homer Lim of PSOM and Dr. Landenberger of Academy for Biomin Therapy for inviting me to this auspicious event in this very nice location, nonetheless. So when I was first asked to talk about regenerative sports medicine some 10 years ago, more than 10 years ago, by the local society, these were the topics that I included in my talk. So intra-articular hyaluronic acid injection, platelet-rich plasma, which was very, very new back then, human growth hormone infusions, prolotherapy, which is actually inciting inflammation inside joints in an effort to trigger the body to heal the joint in particular. Hyperbaric oxygen therapy, which I've been doing for more than 30 years now. Autologous cartilage implantation, which is also new back then, which was an offshoot of stem cell research, and of course, stem cell therapy in itself, which was very difficult to do in the Philippines back then, till now actually, with lack of guidance and regulations. So, more than 10 years after, it's practically the same conversation that we will have this afternoon, except that, sorry, what happened?
Yeah.
Okay. Except that medical technology, science, research has evolved, and we are now going from something that we barely understood more than 10 years ago to something that we really understand now and can actually apply into more specific indications. As we all know, in the practice of medicine, you use a new technology indiscriminately, it discredits the performance of that procedure. So the same with each and every one of this. So the human body is actually made up or influenced, as the talk to lectures ago stressed on. And of all these, the most challenging and yet the more tangible would be your structural or physical factor or aspect of the human body. But let us take this talk on the context of the fact that the body heals itself. Agree? That's why we're all here. That's why we're practicing in the way we practice, and that's why our society exists. But only if we provide everything that it needs. Okay? As conventional doctors, we were trained to advise our patients not to take supplements, not to indulge in all these substances that will put additional load in our liver or our kidneys because all we have to do is take a well-balanced diet. But so far in my practice all these years, I'm beginning to believe there's no such thing as a well-balanced diet. Or we have to balance it for each and every single one of our patients, correct? There. So let's start with supplements as something to enhance our patients' performance, okay? So in my practice, I've been dealing with a lot more patients who are really not sick at all. In sports medicine, you run that risk of finding patients in your clinic challenging you to make them perform better. So what do? These athletes, and mind you, all of you are managing athletes. Each patient that you see in the clinic is an athlete in its own right or in its own mind. Okay? So these additional activities that our patients do present a challenge that imposes special requirements on his or her mature or aging body. But there is no evidence to date that supplementation with these products enhance performance. And since I've been handling a lot of professional athletes, a lot of these I have to use sparingly or even judiciously, because most of these substances that we will be mentioning are in the WADA list, the World Anti-Doping Agency. So they cannot compete with these substances in their bloodstream. So the pros and cons of supplementation to enhance physical performance will be, first, to improve performance. That's why they're there in your clinic. Faster recovery from whatever they're doing, either training or competing, and targeted nutrition, which is not only effective, but has to be convenient. Okay, all throughout today, we've been hearing, don't skip breakfast, don't skip breakfast. But we see patients on intermittent fasting skipping breakfast. Why? Because it's convenient to skip breakfast. We're rushing out of the house to work. The easiest meal to skip is breakfast. But we have to keep reminding our patients that if we skip breakfast, we drive our bodies back to hibernation mode in terms of metabolism. That's why people who use intermittent fasting as a form of weight loss program, they plateau very early on. The cons of supplementation, it was mentioned, allergies. If a substance does not have any adverse effect, it does not work. It was mentioned by Dr. Arnold. Added costs. We all know that the Philippine Commission on Sports does not spend for our athletes, the parents do. We all know that. So it's an additional cost for our parents, athletes' parents. You can ask Carlos. Okay. Now, as a molecular biologist, I've never forgotten the tricyclic acid cycle. And I indulge each and every one of you now in the audience to please go back to your Harvard's biochemistry textbook and take a look at what Hans Adolf Krebs and William Arthur Johnson published in 1937, which gained the Nobel Prize for Physiology for the former in 1953. And that's the original journal in which it was published. So it looks complicated, but for most of you, you're familiar with everything on this chart. You see your vitamins, which are acting as coenzymes to be able to power this cycle through. And each cycle provides 10 ATPs. Okay, that's your currency for energy of the body. And all you need is 2.5 of NADH and 1.5 of FADH2. So all of these cycles will only push through if all these vitamins are present. And this happens in your powerhouse of your cell, the mitochondria. Now, to dive deeper into the process, you see here your vitamin A, D, and B. Now, as we all know, vitamin A and D are fat soluble. So they're the only ones who cross your nuclear membrane into the DNA, triggering it into transcription of special proteins which provide more energy for your patients or your athletes. Now, the B remains outside in the cytoplasm, in the mitochondria, to produce more ATPs for energy. So you have to have adequate amounts of A, B, and D in order for your Krebs cycle to cycle through. And here is your vitamin C, which we have been talking about for the whole day. Your C, your E, and your fat-soluble vitamins E and K, which can also cross your nuclear cytoplasm or your nuclear membrane, thus triggering transcription again of much-needed proteins to power on or propel your tricyclic acid cycle. So we doctors are very, very fond of classifying things, categorizing things. So in discussing supplements with your patients, you can break them down into these 4 categories. So one, your elemental minerals. You're beginning with your electrolytes, which affect you on an hourly, day-to-day basis. Your sodium, your chloride, your potassium, most especially for muscular contraction. Basic vitamins, you've heard about it, your water-soluble vitamins, particularly vitamin B, your fat-soluble vitamins A, D, and K, and E. Ergogenic aids, the more common ones, the most popular ones among athletes are caffeine and creatine. And your superfoods, which were mentioned a while ago or 2 lectures back, as your anti-aging supplements. Now, you don't need special tests to determine if your patients are deficient of these basic minerals, basic vitamins. All you have to do is get your electrolyte balance with your usual chems. You get a trend. All you have to do is look at your CBC, your complete blood count. Your hemoglobin is adequate, but your MCHC is elevated. That means the body cannot produce enough red blood cells that it has to pack each cell with hemoglobin. What that tells you is you are dealing with a patient who is low on vitamin B complex, particularly folic acid. So you have to replace these things. Now, I would like to stress on replacing these elemental minerals and basic vitamins because not only does the Krebs cycle does not power through without them, number two, you cannot enhance performance if you do not have the basic performance to begin with. We talked about hormone balancing this morning, microbiome normalizing or balancing as well. So all of these things are very, very crucial before starting to even dream of enhancing the performance of your athletic patients. Okay, we mentioned creatine supplementation. This is very popular among patients, athletic patients, especially the bodybuilders and the high-level athletes. Creatine supplementation is safe for short and long-term intervals. These are both for healthy males and females, younger or even older. So if you have a patient 40 years old and up, wants to play with his teen children, then this can be a good ergogenic aid on an as-needed basis or on a continuous basis. Okay? The presented dose is the one recommended, 0.3 grams per kilogram per day for 3 to 5 consecutive days and an interval of 20 grams per day for 5 to 7 successive days. So you can also do a regimen of 3 to 5 grams per day over 4 weeks if you don't want to deal with computing with or against the weight of the patient. So this is usually good coupled with a high carbohydrate and high protein diet, particularly complex carbohydrates, not simple ones, so that you could increase or expect the much needed muscular development you would on a patient on creatine. Okay, so we're dealing with vitamins. You saw in the Krebs cycle that you only have 9 of your amino acids that you need on the list because the other ones are essential. Your body cannot make them. So who makes them for your body? Your microbiome, with the help of absorbing the right elemental minerals and vitamins. So you have to have a well-balanced gut biota. So specific combinations of supplements cannot be, as they say, across the board or one size fits all. They can only enhance a patient's performance if they are customized or tailor-fit or bespoke for that patient, meaning addressing each and every deficiency that you feel the patient has or see from the tests the patient has. It was mentioned this morning that several bacterial genera are common in the distal intestine and they are known to synthesize vitamins, particularly thiamine, folate, biotin, and riboflavin. These are and pathogenic acid. These are your vitamin B complexes. So you have to have these gut biota in the form of taking organic or natural probiotics and should be part of your customized formulation. If you were to bake a cake, this would be your chiffon and all the other supplements, the icing. You cannot enjoy a chiffon without the icing, and you cannot have the icing only without the chiffon. So that will make you remember that. You've been having dessert all day long. Okay, any questions so far? All right, let's proceed. In the interest of saving time, we will just go through hyperbaric oxygen therapy. This is an industry that has been booming and mushrooming all around the country in the past 2 to 3 years after the pandemic opened. Now, this is basically the administration of high pressure, high concentration oxygen in a fixed or closed chamber, whether it be for one person or for a barkada or a group of people or a family or a barangay, as we would call it in the Philippines. So this is nothing much more than forced oxygen uptake based on Henry's law of physics, meaning the higher the ambient pressure, the more your gas dissolves into a liquid medium. So instead of your body being dependent on your red blood cells, your hemoglobin, in bringing oxygen into the body and distributing it over the other organs, putting a patient in a high pressure environment will force oxygen to dissolve in his bloodstream, his sweat, his saliva, his eye fluids, everything, delivering much needed oxygen to every single part of the body that is not otherwise getting enough oxygen on a normal barometric or atmospheric pressure. This was initially developed in 1800s for the development for the treatment of decompression sickness in divers, reversing the formation of nitrogen bubbles in the bloodstream. And its application on inflammation was derived from what was observed on high altitude athletes developing pulmonary edema while they train in the mountains. Not too long ago, this has been revisited over and over again and has been accepted by most medical societies. And in my specialty, this has been used now to enhance healing from surgery, particularly that involving graft restoration or reconstruction. And it also enhances pain management with less pharmacologic products. Okay, PRP or platelet-rich plasma. Who among you here have had experience using PRP? Who among you here have had experience using PRP for aesthetics there? For otherwise, non-aesthetics, okay, practically more, okay. So PRP is basically a cellular precipitate from uncoagulated whole blood. Now, why uncoagulated? Because your platelet is responsible for coagulating your blood. So as we all know, for those who have experience using it, we draw blood from the patient himself, concentrated by means of a special centrifuge to collect all the platelets. So this is a microscopic view of a non-concentrated blood sample with the platelets in the smallest blue ones, being spot blue ones. And this is when you have your platelets concentrated. And this is what you see in your test tube. So you have your red blood cell components, some of your white blood in the buffy coat, and most of your PRP. Now, the plasma on top of it is what we call platelet-poor plasma. The thing is, here in the Philippines especially, we don't let anything go to waste. We also inject the platelet-poor plasma in our solution. So, but if you were to do this freehand, as we would say, you try to target getting much of the buffy coat, the orange level or the orange layer, because it contains all of your growth factors from your platelets. Now, why the platelets? Some of you might ask, because the platelets are responsible for being the first responders. When you get an injury, when you get a cut, a bruise, an abrasion, a laceration, the platelets are the first cellular elements in your blood to localize in that level or that area of injury. Why? Because they do contain all of the growth factors needed in initiating healing and treatment of that injury. This is a list of some of the growth factors that you will find in your platelets. I already submitted my slide set from the organizers. You can ask them for this. Now again, the recent history, the American Academy of Orthopedic Surgeons finally included PRP treatments in their armamentarium so that they can charge insurance from doing the procedure. So it's much more accepted now and also in the Philippines. And this is a list of all the applications and studies made on these applications for PRP. So this is just the top 50. There are more. The top ones are tendinitis or tennis elbow, Achilles tendinitis, golfer's elbows. In my practice, I've been using it more for enhancing ACL reconstruction and treating partial tears of rotator cuff, which we used to do open surgery before. Now we don't, unless it's a full thickness tear. especially the ones that are retracted. So I now use a closed system, meaning I don't centrifuge in an open test tube or a plain test tube. This is a kit that we get from Arthrex. If you see, it's a syringe inside the syringe. So once you've done centrifuging it, the yellow or the plasma part gets drawn by the inner syringe, which you can then use just by attaching a needle to it and inject it directly to the site of need. So PRP has been convincingly shown to be efficacious in the setting of patellar tendinopathies, knee osteoarthritis, and lateral epicondylitis or tennis elbow. And there's several recent randomized controlled trials or RCTs that even prove PRP to be superior when injected in a osteoarthritic knee compared to just steroids or hyaluronic acid. Questions so far? All right, so exosomes, we all know what an exosome is. It's a vacuole inside your cytoplasm produced by the endoplasmic reticulum, containing a lot of the healing factors again. So much of these healing factors and growth factors that we find in the platelets, they are contained in exosomes that the platelets emit once they coagulate. And I would like to call them nature's healing gift in small packages. So like the lecture a couple of sessions ago said that we are now tending towards or gearing towards cell-free substrates. Exosomes would be one of them. Okay, emerging applications in sports medicine. I like calling this emerging applications because we have not been able to really put a finger on which growth factors to improve, to develop, and to apply. So we are still studying their significance in sports medicine or musculoskeletal science, but this is being increasingly recognized, particularly in healing athletic injuries faster. There have been studies which have compared against placebo, and that they have found out that healing can even sometimes go on 4 times faster than without exosomal treatments, particularly in structures which have no blood supply, like your articular cartilage, your meniscus, and your ligaments. Okay, emerging applications, we're still studying, but this is a study out of China which put in a schematic diagram how we can look into picking which exosomal factor or which growth factor to develop in which exosomes. Much of this now are going towards synthetic production of these exosomal factors. So this schematic diagram is very much helpful in our research work. And this is a similar study out of Italy, which presents it in a different way, but you get the picture. So this has been the applications currently in orthopedics or musculoskeletal science or medicine. We have been using it for osteoimmunomodulation for faster healing of bone, especially in fractures and osteoporosis. Osteogenesis imperfecta, we have been using it for increasing or decreasing blood supply to specific bones, particularly those plagued with bone sarcomas, and for cartilage regeneration. We have also been successful in using this together with implants, explants, prosthetics, and orthotics. This is one example of a study, but this was for exosomes derived from umbilical cord or placental stem cells. So it shows in the middle part where you have the bone healing, that it closed, the bone defect closed within 3 months as compared to 6 months in the sham population. Okay, next up, peptides. So after your exosomes, in the journey towards cell-free substrates, we have peptides. We all know that peptides are nothing more than short-chain amino acids, less than 50 to be exact. 50 and above, you have your proteins. So most in current research and development are less than 20. Most of those that we use are within the teens of amino acids long. They are always now available in many formulations or SKUs, oral, inhalational, and injectable. We still want or like using the injectable forms as provided by these products which we use much in our practice now. Collagen peptides, there's a good popular brand of oral collagen peptides that most of you must be familiar with. It has been mixed with MSM, curcumin, and all other superfoods to enhance its effect. We have BPC 157 and CJC 1295 and ipamorelin. The last two, or the latter two, are usually put together in stacks. So peptides are usually employed in enhancing healing or recovery among athletes who are in high-level training or have been frequently injured. So pentadecapeptide is a 15 amino acid long peptide. It was born of partial sequencing of a body protection compound found in the gut, in the stomach lining back in 1993. So they found out that this is responsible for relining against your pH 1 acid in your gut. So this is naturally produced, enzymatically stable, and can be now synthesized in the laboratory. So it has a huge range of organoprotective effects, not only in the stomach, but all over the body. It has been shown in this retrospective study by Edwin Lee, who practices out of Florida, that it helps reduce knee pain when injected directly into the joint, which is actually a primary complaint in our field. So after receiving a 4 milligram injection of this substance, 11 out of 12 patients, a small population but nonetheless effective and bias-less, experienced relief from knee pain. So we are starting to use more and more of this, not only relieving our patients from pain, with pain, but also to keep them from getting knee replacement early. Okay, these are the different peptides that we have come across, and the most effective ones that we've seen for musculoskeletal medicine is CJC 1295, and as mentioned, your BPC 157. So these are either injected directly into the joint. The dose is usually for BPC 157 is 300 to 500 milligrams per injection per day for 5 consecutive days. And then we cycle this every 4 weeks for every quarter. So the next one is CJC 1295, which, like I said, we usually stack with ipamorelin. Ipamorelin was discovered actually earlier in 1998. And this is the first selective growth hormone secretagogue. So it stimulates your growth hormone receptors very much like your CJC 1295. So if you put them together, as seen in the graph, they have a synergistic effect rather than being used one or alone or independently. Any questions with peptides so far? Just a caveat with peptides, there's still no fixed regimen or protocol. So most protocols suggested by these evidence-based studies usually recommend injecting them intramuscularly or directly into the joint of need or the area of need. Okay, so no regenerative talk would be complete without a mention of stem cells. Okay, so these are, as you know, naturally occurring pluripotent backup cells of the body. So they are lurking in your bloodstream, in your bone marrow, which is actually how I got to get introduced to them. I would use bone marrow aspirate, not knowing that I was deriving stem cells, and injecting them into fractures which have not healed at the expected time. Currently, these are the applications that we have in musculoskeletal medicine, where stem cells have been showing much promise. Disc degeneration, like mentioned, non-unions, meniscal injuries, which we used to just take out in the past. Now we can repair and regenerate. The reason being, if you take out the meniscus, you end up advancing osteoarthritis in a particular joint or a particular patient. Tendon and ligament injuries, which we used to suture openly before, we just inject them with peptides, stem cells, exosomes, and they heal without surgical intervention. Muscle injuries and articular cartilage damage, as mentioned. Now, as we all know, mesenchymal stem cells can, being pluripotent, develop into a lot of these tissues musculoskeletally. They're also maintaining their numbers through self-replication. And then they can specialize into any of these cells. And this is an example of what we used to do. So we would, for an osteochondral defect of the knee, this is an arthroscopic view, we would clean it, do microfracture to create a stem cell communication between the bone and the cartilage substrate. And then what we used to do before was get samples, or what we call biopsies, send it to a lab, and the lab proliferates or multiplies these cells. And then once we have the cellular growth, we put it on a matrix and plug it in. So back then, it was a 2 to 3 stage procedure. So this is how we describe it. We get the biopsy, we prepare it in the lab, store it, positive isolation of stem cells and chondrocytes, cell culture into chondrocytes, and then they give it back to us as chondrocytes in this meticulously run lab. It was fun, but I never knew that I would be wearing PPEs more than the laboratories. Pandemic happened right after this. So now what we do is, since most of the damage or injuries that we get are in this schematic diagram of the knee, we get a lot of it, 11%, in the osteochondral, the patellofemoral articulation. Much of the athletic injuries, though, we get on the medial condyle, femoral condyle to be exact. So that site where you saw with an osteochondral fracture is actually the medial femoral condyle. So what we do now is we went back to autologous, get bone marrow, mix it with epidermal growth factor, another exosomal preparation, which we have now in the market, and create a substrate. So we don't have to grow cartilage right there and then in the laboratory. So what this does is it makes a 2 to 3 stage procedure into one. So we create a plug out of epidermal growth factor, bone marrow aspirate, and matrix. Matrix usually is the same material you use in cementing your teeth. And we inject it like this. And we do it arthroscopically, so no need to open the knee again. And we've been getting good results, having improvements on MRI in 2 to 3 months instead of 4 to 6. Okay, so to summarize, because some of you might be looking at me like my dog does. So these are all modalities that not only musculoskeletal specialists can use. We really are very aggressive on the study, particularly clinical studies of exosomes and peptides. And a lot of these have proven very effective in facilitating healing of musculoskeletal structures, and you can do this on your own as well. There are at least 2 or 3 companies in the Philippines now selling peptides. Not only the ones I mentioned, but also semaglutide, for example, which is very much in demand now because Ozempic ran out. So you can tap these companies for that as well. So I leave you with this cartoon. So as much as we are tending towards a cell-free substrate in regenerative medicine, we are also tending towards a take-out in surgical procedures. So I hope I was able to add to your armamentarium of knowledge today, as much as my dogs are whispering to each other.